first one's about a 52-year-old woman who presented with chest pain. So she is a Pashto-speaking, which is a Pakistani dialect, woman with past medical history of hypertension, dyslipidemia, diabetes, and GERD. Originally presented to Salem Hospital with chest pain times one day, or on a weekend. She basically has had episodes of substernal chest discomfort at rest for the last few months, but she also has significant history of GERD, so she usually just waited them out and they self-resolved without any medications. No associated fevers, chills, lightheadedness, dizziness, leg swelling, dyspnea, orthopnea, or any other symptoms. However, the current episode felt more intense than her usual ones and also lasted a lot longer, so she ended up at the outside hospital. As I mentioned, her past history is significant for hypertension, dyslipidemia, diabetes, anemia, and GERD. No relevant surgical history. Family history is significant for diabetes in both her parents. For home medications, she takes aspirin, Lipitor, metoprolol 25 twice a day, Protonix, insulin, gabapentin, and Lasix as needed for leg swelling. And social history, she does not smoke and no history of any other drug use, and she's a homemaker, but pretty active around the house. Her physical exam when she came in at outside hospital and over here was grossly unchanged. So my exam was she was in no acute distress, no significant JVD, lungs and lower extremity were unremarkable. She was tachycardic on exam with a regular rhythm, and she had a harsh 2/6 systolic flow murmur without any radiation. She was obese, but otherwise her abdominal exam was benign, and her vitals were significant for lipid hypertension of 150s over 60s, heart rate in the low 100s, and otherwise her BMI was 34.5. And this was her admission EKG.
This is her admission to Salem?
Yeah.
Okay. All right. So far, pretty straightforward. Dr. Weisstocker, are you here? I didn't see the participant list.
I'm here.
Great. Good morning.
Good morning.
So we have a 52-year-old woman who has multiple coronary risk factors: hypertension, hyperlipidemia, diabetes, on insulin. We didn't hear how long she has diabetes.
More than 10 years.
More than 10 years.
Yeah.
And she had several months of nondescript chest pain, not particularly exertional chest pain, but she presents to Salem because it seems to be becoming more intense in some way. Examination was unremarkable except for a recorded heart rate of about 100, and this is her admission ECG. So she presents to the ED. How would you evaluate?
Yeah, well, the story is very concerning because of the multiple risk factors that she has, but the ECG really doesn't look like it matches this story. She's not tachycardic on the ECG. She's in a sinus rhythm. There's good R wave progression across the precordium. The inferior leads look okay. Really not much per se on the ECG. The intervals are good, PR, QRS, QT. So pretty benign looking ECG, but the story is very, very concerning. I was also interested why she was taking aspirin, although that may prove to be a good thing, but she has a history of GERD and other issues and no coronary disease, and she was taking aspirin and high-dose statin. So her management was even very good if it turns out to be a coronary case. So anyway, the bottom line is, from the ECG, you're not calling the cath lab. You would probably maybe want to check some enzymes, maybe at some point get an echo because there's a murmur, but it doesn't look like LVH like you'd see with AS. So pretty not pointing to the heart from this ECG.
The physical exam describes a murmur that seems like it's a aortic murmur or an outflow murmur. How would that play into your differential diagnosis?
Yeah, well, the murmur is of interest because she's kind of the wrong age in a way. I believe she's 52. So, the murmur is an outflow murmur like you would see with aortic stenosis, for example. But 52-year-old would have to be a bicuspid valve. There's no history of that. She doesn't have LVH on the ECG. What else could it be? There could be thickening of the septum. She could have, a hypertrophic type pattern. But again, ECG doesn't favor that, and there's nothing in the history to favor that. outflow murmur can also be, she was tachycardic at that time, 105 heart rate. You can have benign flow murmurs as well. They're not always pathologic just from high flow. If she has a very dynamic heart, the blood ejecting through the aorta can make a noise of its, in and of itself without obstructive physiology. So, the murmur doesn't give me the diagnosis. Now, again, assuming that we're getting the right description of the murmur, systolic murmur, outflow murmur, it's either, aortic outflow or pulmonary outflow. I see nothing on here to go with elevations of the right heart pressure. So yeah, I think right now with the chest pain and the murmur, we don't know. I think an echo would be a very great test to get us started.
And I'd like to comment, I believe that the American Diabetes Association does recommend, I don't know about high-dose statins, but certainly statins and daily aspirin for.
Yeah, absolutely. My point of that, Rick, was that she is well treated. She's aggressive.
Exactly, despite her good preventive treatment. Exactly.
Right.
Okay, let's.
Oh, there was just one thing I didn't mention it, but there was a wide pulse pressure described. I believe the diastolic was like 50 or something. So, you think of aortic insufficiency, but we didn't hear the murmur of AI, and certainly the ECG doesn't have. Usually with AI of a chronic nature, you'd have high voltage too. So again, that doesn't fit. But you think of that with the wide pulse pressure. I'm sorry. Go ahead.
Right.
X-ray.
Perry, you want to comment on the X-ray?
Sure. So the X-ray is slightly rotated, not too bad, a little bit rotated. The cardiac silhouette does look generous to me. Again, for a seemingly healthy 52-year-old, looks a little big. Again, it's rotated, and we have to evaluate that better. I'd like to see a lateral view to know about the right heart. The left heart is maybe big, but the right heart might be big. I don't see any pleural effusions. There is, maybe they hint at some slight pulmonary vascular distribution, toward the apices, but really not much. The pulmonary arteries are hard to judge from this view. They could be generous, but I would say the biggest finding here is this cardiac silhouette's large, and we'd have to explain that.
Her initial lab results were notable for anemia with a hemoglobin of 9.1. Basic metabolic panel had elevated glucose. Otherwise, LFTs were within normal. A1C was really elevated at 8.7%. Her COVID was negative. Pro-BNP was unremarkable, but her troponin I over there was notable for 0.2 and then peaked at 0.35 and came down to 0.3. For the anemia, she had iron studies done, and as you can see, her ferritin and iron was really low. Notable for iron deficiency anemia.
Are you familiar with what is the normal upper limit of normal electrophone? That one was 0.05.
Yeah, that's the one with 0.05. Yeah. So at Salem, her course was notable. She was given aspirin, stat, and started on heparin for the elevated troponin, and given sublingual nitro as needed. Her EKG, as we mentioned, had non-specific changes. So she was admitted to the floors, and again, her chest pain self-resolved this time. GI and cardiology both were consulted. GI requested cardiac clearance for endoscopy, and for us, we were concerned with the story and with the elevated troponin, so we transferred her to us for cardiac catheterization given her risk factors.
All right, so Dr. Rachi, what do you think about that? You have a woman who comes in with acute coronary syndrome, normal ECG, but positive troponins, but progressive chest pain, and now she's anemic. It looks like iron deficiency, and now you're left with, okay, you're going to potentially intervene and put her on dual antiplatelet drugs, but potentially bleeding. How would you approach her workup and management?
Well, a couple of things about this case. Look, one is it really acute coronary syndrome? That's number one. If we're convinced, especially clinically, that's the case, then I think to proceed to the cath lab is reasonable. The other question after you make the decision that she should have a cath, what about the GI issues? That's a problem we face every day almost. The bottom line, I think doing a cath is reasonable because doing a cath doesn't mean an intervention. Although for all practical purpose, it does for at this point. I mean, you cannot go find 90% lesion and leave it alone because GI will not do anything. So the question is GI eval first or cath? I think I would. There's no acute bleed here. She's not hemodynamically compromised. Uh, Doing the cath and act upon to it, you have to treat what you see and then deal with the anemia at later day would be the simplistic approach.
So, Dr. Mazzarelli, you're on the call. Do you agree with that approach?
Can you hear me? Hopefully you can hear me.
Now I hear you.
Yeah, no, I mean, I think what the important thing that Dr. Aji said, it was, doing a cardiac cath can be diagnostic. I mean, you can always do a coronary angiogram and then pause and then reassess what you're dealing with, So if this person, they do the diagnostic test and the person has, severe left main, that's a lot different than having, a distal RCA lesion or some, small vessel. So I would be pretty worried about not knowing the risk of future bleed in a patient who may need dual antiplatelet therapy. I'm stating the obvious by stating that, but you just have to figure out the predominant pathology. And it sounds like there's no doubt she's coming in with, angina and non-ST elevation MI. So, yeah, I agree for the most part.
Is there anybody who would clear her for GI studies without doing a cath?
Oh, can I just add that
Yeah.
I don't necessarily think that doing a cardiac catheterization magically makes her better for a GI procedure, which is extremely low risk to begin with. But
Right.
if she's actively there saying she's having chest pain, I mean, it's kind of hard not to do something about that.
Yeah, I agree. But this, I mean, even for low risk procedures, this is the highest risk patient. Somebody's in the midst of an acute coronary syndrome. So I think you want to know what you're dealing with, define what the coronaries are doing before you make a decision about other things. Okay.
So she went straight to the cath lab when she landed here. And these were her images.
John, did you do it? Did you?
I did not. I think Brian did.
All right. I know if Dr. Corbett's on the line, you can comment on the study. Otherwise, I'll ask Dr. Algi to comment on the images.
It was Dr. Eliades.
Oh, Dr. Liao, sorry. Leo, are you on the call or?
Yes, thanks. No, I think hearing the discussions, I think appropriate management was done in that we took her to the lab because you need to risk stratify this lady. And I agree that you don't always have to intervene unless you're staring at 90%, then you make some calls. You kind of figure out what you're dealing with. The panel on the left is the right coronary artery, is in the LEO projection. And too much. That's all I get. I think you have a great morning. And really, it looks from here a mild disease, not terribly. So the PDA is actually quite small in that picture. Oh,
Want to pause it?
yeah.
Caffeine to the computer.
The panel on the right is the one that's concerning, and it appears that there's, yeah. There's as the frames are going quickly, but you appear there's a tapering in the distal left main, which appears significant, significant reduction in the left main size. There it is. Okay, thank you. The circumflex has some obtuse marginal disease. There's some distal second obtuse marginal disease, which is pointing to right now or coming down to. And then the LAD proximally has probably moderate disease as well in that frame.
Even though she has focal stenoses, the coronaries look very calcified. It's calcified without a focal stenosis
correct.
and a proximal LAD insert.
Right, so fairly calcified. Correct.
Okay, that's great to pause on that. So, Dr. Raji, is there any, sometimes the left main lesions are tricky and, we're just looking at geography can be misleading. Is there any question that this is severe left main disease?
Yeah, I mean, we used to trash angiography all the time. But the angiogram is very powerful when clear like this. And this is no matter how you look at it from whatever view. Granted that the assessment of the stenosis could be wrong, but this is severe no matter what view you look at it. So I don't think here you have problem calling it. Is it significant or not? It's more of a management issue. She does have severe left main. That's the bottom line.
No need to, you wouldn't IVUS that stenosis.
I would not IVUS it unless I have to intervene on it. In terms of severity, it's clear the severity. The question, if we're going to go ahead and treat it with percutaneous intervention, then probably IVUS could be helpful.
I think you can make a pretty clear case when you look at that view that it's a complex distal lesion. So it's not, you're tempted to say it's just a distal left main, but it clearly extends well into the LAD. You can see that the caliber of the LAD around the, I don't know what that is, around the first septal that you can see going down gets larger, and that's more than just post-stenotic dilatation. So there's probably a 50, 60, 70% stenosis of the LAD in a long segment. So you would have to do a really complex reconstruction. This isn't a discrete left main lesion of the kind you can put one stent in and leave it alone. And very typical, by the way, as you know, I've studied coronary disease in the Indian population, and the diabetic Indians have a particular problem with diffuse multivessel disease. And these lesions are diffuse. They're not, I mean, it's a long area of severe disease.
That's a really good shot for showing how much calcium is in there. It looks like almost instant stenosis, except it's a native vessel with lots of calcium. I think that also that shot points out what Dr. Turi is talking about, that lesion extends into the proximal LAD quite significantly, above the septal there.
Mm-hmm. So the distal left main disease, as I'm going to show you a couple of slides, is almost always extend into the ostial LAD and the circumflex artery, just the nature of the disease. So may look angiographically, it's focal distal left main, but if you IVUS it, you definitely going to see severe ostial LAD, severe ostial.
So as we all saw, she had 80% distal stenosis with proximal LAD, 70% heavily calcified. She also had SUG disease and mild RCA disease. She was admitted to the CCU given the left main disease, and then cardiac surgery was consulted.
All right, so Dr. Weinstock, what do you do now about her GI workup? She has acute coronary syndrome with tight left main. Do you wait till after the surgery or do it now?
Well, this is a real tough one here. She has very critical anatomy, and it's very worrisome that she's ruling in for an NSTEMI. So I mean, it's hemodynamically significant to her heart. So the question is, what comes first? I think you talk to the CT surgeons, obviously that's done, and you talk to GI and see what the likelihood is here. She didn't have, from what we heard at least, she didn't have bright red blood per rectum. She didn't have melanotic stools. She's probably got an upper source or a lower source that's trickling, that's dripping enough to make her anemic, but not to make her hypotensive. So I think
the GU source too.
yeah, that's true. It could be somewhere else. Yeah, absolutely. But I think the point was said earlier. I think Dr. Aji mentioned it. No GI doctor is going to do an endoscopy on her because they're going to say, "Well, wait a minute. She just had an NSTEMI. Our literature says don't put the scope down on those patients." So I think you're going to have a hard time getting a GI doctor that's going to want to do something unless she's actively exsanguinating, which she isn't. So I think the GI workup's going to have to wait. The real problem is going to be, our choice of antiplatelet medicines or anticoagulation around the time of surgery, heparin, et cetera, in the OR, and then afterwards, does she get daily aspirin? I think that's where the rubber meets the road, is how are you going to handle that? But I think for right now, I can't see a pathway where you're going to scope her first with 80% distal left main and positive troponins with chest pain. I think it would be difficult to argue about scoping. So I think you revascularize first, unless she's actively, showing you melena or something like that, where the heart surgeons are going to step back. I think you actively fix the coronary lesion that she came in with.
Let me just also back a second. So in retrospect, this is a woman with unstable pattern chest pain who has severe left vein disease, who had a normal electrocardiogram when she presents to the ED. Are you surprised with that, or is that just sometimes that's what happens?
I think that we've seen this so many times, it's ironic, but sometimes the more disease you have, the more normal the ECG is. Because a lot of these things, there's a lot of ischemic preconditioning. This disease didn't happen abruptly. So, you rupture an LAD plaque and all of a sudden you have, anterior STEMI and Q waves everywhere. But something like this is insidious. It happens over years. The heart kind of comes preconditioned. They don't have an infarct. So I don't think it's unusual at all to see no Q waves on there. In fact, if you think about it, if she had Q waves, it would have been a pretty devastating
I
event.
think the
What was that?
Yeah, I think the traditional teaching, I think, was that about 15% of ACS, true ACS, will present with a normal ECG. So I think it's not that uncommon. So the fact that someone has a normal ECG should not dissuade anybody that's evaluating these people from thinking that there may not be severe coronary disease.
I think that's particularly true of multi-vessel. Yeah.
Yeah, this guy I used to have was one of the previous chiefs here at Cooper. Is the EKG such a good diagnostic tool, or the EKG bad diagnostic tool? And I always on the side, it's not a good diagnostic tool because you miss a lot with normal EKG. You miss almost third of the disease that encompasses left circumflex artery, and you miss left main with it a lot of times. So there's a pretty significant disease. So it really does boil down to the clinical story.
I take offense to that.
Yeah. So two observations, one from working in India some 30 some odd times over nearly 40 years, is a very common presentation in the Indian population, doesn't particularly apply to this lady, but is iron deficiency anemia, which is very common and usually dietary, and this lady could easily have something nasty in her gut. That's a population in which sometimes we treated the anemia rather than the coronary disease. That was partly due to the hardships of where we were working, but was quite effective and certainly exacerbates the symptoms that patients have for any given amount of coronary disease. And the second, there's a lot of calcium in this lady's coronaries. She probably has calcium in her aortic valve. No one commented on it, but there was no calcium that I could see on the angiogram. And so we didn't talk about it, and the physical exam would actually have been done, had to have been done professionally. But aortic sclerosis is a very common cause of systolic flow murmurs, and has a very poor prognosis in and of itself, and is associated with atherosclerotic disease, and would be very high on my differential based on what I see so far.
I would like to add one thing to that, because it may not come up in this case, but you should be aware that this is the population that it would be very important to check a lipoprotein A, LP little a level. statins will not treat Lp(a). The Indian population, other populations of the world have a high prevalence of that, and lipoprotein A is a marker for badness for lots of extensive coronary disease. And again, the statins will not adequately treat that. So this is, that's something to keep in mind as we move forward. She's going to get revascularized, but she may, continue to progress with her coronary disease unless we address that concern.
Harry, what does treat that?
I'm sorry, I missed that, Rick.
Well, what does treat the LP little
Yeah, so that's the great question that we've debated for the last 35, 40 years already. But well, certainly knowing that you have it, you want to be the most aggressive with your therapies. So first of all, it changes your mindset a little bit as a lipidologist. But the things that treat it, niacin can have some role here, not ever proven to be completely, that doesn't cause reversal or necessarily improve mortality. But niacin has been shown to reduce LPA levels. The newest drugs, the PCSK9 inhibitors, do reduce Lp(a) about 20%. They're not approved by the FDA for that because it's a limited population and people haven't studied it per se, but they do lower it quite a bit. And there are some drugs that are in the pipeline actually being worked on by an interventional cardiologist in California named Sam Tsimikas, who is has some, antisense oligonucleotides that will reduce LPA. So there's some promise and some hope. But the reason I'm telling you is that it's a very bad disease. And there was just recently a review, I forget if it was in JACC or one of the other journals, about this and how treacherous Lp(a) is. And so the statins don't hit it, unfortunately. But what we do, to answer your question, is we're maximally aggressive with the statin, try to bring the LDL not just below 70, but below 50 if you can. Because the belief is that if you can't knock out the LPA, at least you can reduce all the other atherogenic lipoproteins to the maximum extent. And they seem to do a little bit better. I follow a bunch of patients that have high LPAs, and when you get the LDL down around 50 or so, this disease seems to quiet down. But this would be a case where I would look at that.
The GI was consulted, and she had been asymptomatic, no melanoma, no GU complaints, and they kind of said, not going to do anything, as we discussed. This was her transthoracic.
Yeah, it's Brett.
Okay.
LV function looks good, and probably some mild LVH.
The aortic outlet, at least that we can see in the conference room here, looks fine. And maybe the aortic root is a little bright, so it's not maybe it was aortic root sclerosis. Yeah.
Yep. I mean, mostly it was unremarkable. EF was normal, no wall motion abnormalities. We were not able to assess any diastolic dysfunction, but really unremarkable echo, except the increased wall thickness. So cardiac surgery was consolidated. Took her for a 2-vessel CABG with a lima to the LAD, and then REMA that was wide from the lima to OM. Kind of interesting. She had really also had a pretty unremarkable course post-op. She was started on aspirin, Plavix, and statin. Slowly was also started on beta blocker, and then was given a couple of doses of Lasix, but generally needed a standing dose. And she was going to follow up outpatient at Salem in 3 weeks.